First, we're going to hear from Dr. Schepis, who is a professor in the Department of Psychology here at Texas State University and a faculty fellow in the university's Translational Health Research Center. Now I will hand the conversation over to Dr. Schepis to get us started.
Well, hi, everyone. Thank you for coming today. I appreciate you taking some time out of your Friday to take part in this. And again, we're looking forward to discussion at the end. So today's topic is focused on the intersection of substance use and suicide. And just to give you a very brief overview, because I'm going to, again, be talking somewhat briefly, and then we will have Dr. Goetz talk about things from a little bit more of a clinical perspective. I'm going to be covering the research perspective. I'm going to talk a little bit about the evidence we have that links suicide and substance use, talk a little bit about some potential mechanisms, how we think this might occur, and then talk about some higher risk groups that we want to highlight for attention. Certainly isn't going to be comprehensive. And if you are interested in suicide more broadly, I would encourage you to go back and get the video from Dr. Megan Rogers, who was the first speaker in this series, did an awesome job of giving an overview of suicide and suicide assessment that I think is really valuable. So I am going to go ahead and get us going. Again, by way of overview, and Dr. Rogers is the one to refer to on this more, in the United States in 2022, the Centers for Disease Control noted that over 49,000 people died from suicide. And that's roughly one death every 11 minutes. But as you can see over on the right of your screen, this doesn't capture the full extent of suicidality's impact on people in the United States. While 49,000 people died from suicide, over 13 million people seriously thought about suicide. Over 3.5 million, 3.8 million made a plan for suicide. And then at its most severe level before an actual suicide completion is a suicide attempt, and 1.6 million people attempted suicide. That number tells us that the vast majority of people, not just who think about suicide, but who even attempt suicide, do not complete suicide. And so we've got a group here that's a very large group and a very distressed group. Even if a person does not attempt suicide, making a suicidal plan is a very serious indicator of mental health distress, and it's something we want to pay attention to. So this is another way to look at suicide in the United States. Again, this is from the CDC, and you can see from 2000 to 2018, there was a 37% increase in suicide deaths in the United States, going from about 10.5 out of 100,000 people to almost 14.25 in that time frame. There was a small decrease from 2018 to 2020. And then, of course, we all know what happened in 2020. COVID hit and rates returned to roughly where they were prior in 2018. We don't have really newer data than that necessarily that's extremely reliable, but you can see this overall increase with an interesting downturn that hopefully we can replicate in the future. So in terms of links between substance use and suicide, let's narrow in a little bit and go from our broader focus on suicide. Research has really consistently linked acute substance use, so substance use in the moment, at that time, being intoxicated or under the influence of alcohol or another drug, and then heavy, consistent substance use to suicide. I'm going to talk about this figure over here on the right in just a sec, because this is something, if you're not familiar with meta-analyses and research literature, this is probably going to be a little foreign to you. I'll highlight how it works. But lighter overall substance use may not necessarily be a risk factor for suicide. So this is a 2017 study that took a set of articles on links between suicide and alcohol use. And to be clear, they were looking at suicide completion, not just attempts, not just suicidal thoughts, not just suicidal ideation. And what you can see here is that the top 3 studies have this diamond in the middle, and they have these wings basically that go out. And those are kind of the confidence intervals that tell us about how confident we can be there's actually an effect going on. And those top 3, they don't show any difference from what we would expect. They're not significant. But that final one does show some kind of effect. And again, this is any acute alcohol use. This isn't heavy use. This isn't binge use. This isn't an alcohol use disorder. And ultimately, the authors concluded that there was a smaller but real link between lighter alcohol use, any alcohol use potentially, and suicide. So how would, and we're going to talk about different drugs a little bit later, but how would an attempt like this occur in the context of substance use? So you can start over on the left with acute, even heavy substance use. And typically this is going to be heavy substance use. An individual who has one drink is not going to become significantly more suicidal. But when an individual uses substances somewhat heavily in the moment, what we see is that A, they have increases in impulsivity, increases in aggressiveness, and that aggressiveness can become self-directed instead of externally directed, and dysphoria. Now, for dysphoria, for sadness, for anxiety, for agitation, all of those sorts of emotions, that may actually be a function of withdrawal, not necessarily the acute substance use. So that may be a little bit more complicated, but certainly as someone uses alcohol and then stops using, begins to come down from that high, dysphoria is pretty common. Those are increased with acute substance use. And then on the other hand, adaptive coping and good problem solving are impaired, as are barriers to self-harm. The mental set of thoughts and standards, conditions that someone might have that prevent them from attempting self-harm, attempting suicide, become impaired. And when you combine those two things together, increases in risk factors for suicide and decreases in barriers to suicide and good coping, that can increase the likelihood of a suicide attempt. Now, obviously, this is just for acute substance use. This isn't when we're talking about somebody who perhaps has a substance use disorder. And this is more of what this slide might capture. Even if the person doesn't have a substance use disorder, heavy ongoing substance use in the moment leads to all of those things that the previous slide highlighted. Poorer coping, lower barriers to self-harm, and increases in impulsivity, dysphoria, and aggressiveness. But both the substance use and that increased impulsivity, increased aggressiveness, poorer problem solving, both of those things can lead to poor psychosocial outcomes. You certainly can see somebody who's intoxicated on alcohol, again, instead of turning that aggressiveness inward, they turn it outward and they get in a fight. They have an accident, they get a DUI. All of these things then can make substance use more likely because the set of psychosocial outcomes that that person experiences are much poorer. Their circumstances worsen. Now they have criminal justice contacts. They may lose a job. They may lose friends and that important social support. And all of that can then feed back into substance use. We see this in substance use disorder. One of the criteria for a substance use disorder is using outside of social situations, solo use, and losing hobbies and social contacts in order to use. And all of that can feed on itself. And certainly I haven't highlighted it here, but ongoing mental health problems, whether that's depression, an anxiety disorder, bipolar disorder, those can feed in, and all of that makes a suicide attempt much more likely. So the good news is, though, that there are multiple points where intervention could occur, and they're not just necessarily on substance use, although in these models, again, I'm highlighting substance use. That's the link we're talking about today. And that link can be intervened on with substance use interventions. So that's an important time when we could step in and lower these risk factors for suicide by lowering substance use. Okay, so again, I said I wanted to talk about individual substances. I want to come back and talk about that now. This was a very recent paper by Athy and colleagues in Drug and Alcohol Dependence Reports. This one is publicly available if you're interested in it. It's pretty easy to find. And I'll have my email up at the end of the talk. If you want a copy, I can get it to you or I can direct you to it. Again, it's freely available for download. Alcohol misuse in their study, but not any use, was linked to suicide. And again, this is suicide death, not ideation or a plan or an attempt. This is actually death. And for this, as a substance use researcher, that's my background. I don't love the term alcohol misuse because I don't totally know what that means. But in the paper, they roughly define it as a use disorder, as binge use. So we can kind of get an idea that we're not talking about my pattern of alcohol use, where my wife and I are increasingly old, so we share a beer sometimes at night. We're to that point in our relationship with alcohol. And I might have half a beer 2 nights a week. That's not going to increase risks for suicide. It's binge use, it's consistent heavy use, a use disorder. And then in order of increasing risk, tobacco or nicotine use, then cannabis use. They also looked at opioid misuse and amphetamine stimulant misuse. And I would caution that for those last two in particular, appropriate use of a stimulant medication for ADHD. I'm involved in a lot of research funded by the Food and Drug Administration to look at stimulant medications and their safety over the long term for use with ADHD. And what we're consistently finding is if the medication is taken appropriately, as prescribed, consistently, that person has no different risk for suicide or substance use, other substance use, and substance use disorder than a person without ADHD. So it's not about using an opioid. It's not about using a stimulant medication for ADHD. It's about inappropriate or misuse of those medications. Interestingly, and I'm going to highlight this kind of in the last little bit of my talk, Athy et al. Found that women may be at greater risk. Women who use substances, that is, so that the link between substance use and suicide is more pronounced in women than it is in men. And I want to address that, but I'm going to get into a little bit more recent data here before we do that. So what I have here is data from the 2023 National Survey on Drug Use and Health. So this is a data set. It's actually publicly available. And it surveys a sample of the United States population 12 and older in a household setting, although since the onset of COVID, they also use some web-based surveys. So they'll send those out via email and try and get in contact with folks that way. And what we're looking at here is just adults and suicidal ideation. And again, any past year use. So the question here is use a concerning sign? And what you see is as you go from alcohol, a legal drug in almost all adults once you're at the age of 21, to cannabis, which is in a bit more of a gray area. In some states, it's fully legal. In some states, it's medicalized. In all states, because of the 2019 Farm Bill, there are hemp-derived products that are available. And then you get into illicit drugs, and that includes prescription drug misuse, so opioids, stimulants, benzodiazepines. You see that difference between no use and any use increase. And part of that for alcohol is that most adults use alcohol at least occasionally. In the past year, we're talking about probably 60%. For cannabis, though, it's a much lower number. And certainly for illicit drugs, it's a much, much lower number. So as the form of substance use becomes potentially more likely to be illegal, with greater penalties, greater social consequences for use, you see suicidal ideation start to creep up. So it's not just about any substance use, the type of substance use really does matter. We also see this in adolescents, but with adolescents, we see much more concerning results. So one thing you may notice is that overall, even with no use, these numbers are much higher in adolescents. So again, this is just thoughts of thoughts of suicide. But suicidal ideation, at baseline in adolescents in the past year is 14% in the National Survey on Drug Use and Health. Some of that may be unique to the sample, but I would caution you that they surveyed somewhere on the order of 8, 9, 10,000 adolescents here. So this isn't a small sample. And there are weights that they use in other methodological things to make it representative of the United States. So it's very strong data. And what you see is a much bigger difference, not least probably because all of these substances are illegal for adolescents no matter what. Alcohol is illegal, cannabis is illegal, and illicit drugs, obviously, are illegal. But as opposed to about a 1.5% point difference in ideation for adults who did not use alcohol to using alcohol, now we're talking about 15%. We're talking about over 20% for cannabis and over 25% for illicit drugs. So adolescents are a real population of concern generally, but certainly when they use substances. Okay, let's focus then on a substance use disorder. We're looking at adults here. Are there differences between people who have a substance use disorder and don't? And as you can see on the slide, there are some pretty clear differences. People who may use a substance but don't have a substance use disorder, only about 3.3%, that's roughly 1 in every 33 people, has suicidal ideation in the past year, whereas it jumps to 1 in 8 for someone with a substance use disorder, again, an adult. And you see the same differences for plan, where the number of people who formulate a suicide plan is much lower, but it's still much higher with substance use disorder. And attempts get narrower because attempts are obviously much more rare than plans and ideation. We saw that with the CDC data at the beginning, and you see it here. Last couple of things I want to do are to highlight a couple of maybe higher risk groups. And this returns us to the AFI paper that highlighted women who use substances maybe at being at higher risk for suicidal thoughts and behaviors. And that's what you see here. Though interestingly, you will notice that it gets narrower and narrower as the level of suicidality gets more severe. So again, this is people with a substance use disorder, but there's a really clear difference, about 6.5 percentage points, on something like suicidal ideation. Women with a substance use disorder, about 16%, a little over, have had suicidal ideation in the past year. For men, it's a little under 10%, but then you see that gap narrow significantly to a plan, and there's almost no gap for an attempt. In statistical research terms, this is still, for the attempt, a significant difference between 1.8 and 1.2, but obviously we see this is a much smaller gap. And then one thing I do want to highlight is our friends and neighbors who are members of different sexual identity groups. Here, I'm just highlighting heterosexual men and women, gay men, lesbian women, and then bisexual men and women. But what you see is over on the left-hand side, it's the men, a jump in heterosexual men to gay men, although a relatively small jump. And again, this is among people with a substance use disorder, and this is specific to attempts. But what you see in both sexes is a real jump to members of that sex who are bisexual, who identify in that way. And again, this is another high-risk group. We want to be aware that many individuals who are in a bisexual group are not suicidal. They won't make an attempt, but that risk does go up even more as compared to heterosexual men or women for an attempt when they're a member of that group. So don't just think about substances, think also as you can about higher and lower risk groups, because that does matter and your concern may vary slightly depending on the group. So that is it for my talk. I want to thank THRC for having me. If there are any questions, again, my email's here, and I'm happy to post in the chat if anybody needs it, because I am now going to turn it over to Dr. Goetz.
Thank you so much for sharing your knowledge and this research with us, Dr. Schepis. Just as a quick reminder before we move on, if you have any questions or comments that are starting to arise, please place those in the chat and we will be making time for those in just a moment. As Dr. Sheps alluded to, here is Dr. Catherine Goetz, and she is a senior resident physician specializing in general preventative medicine and public health at the University of Texas at Tyler. Her work involves participation in clinical rotations, including pediatrics, adult primary care, and occupational and preventative medicines. So now I will turn over the conversation to Dr. Goetz to share more about her experiences with us. Thank you.
Hi guys, I hope you can hear and see me okay. So I'm going to talk a little bit today about some of the clinical experiences that I have seen regarding the intersection of substance use and suicide. And this is meant to be more of a conversation, so feel free to chime in. So the first thing I think of when I think about suicidality in a clinical setting in general is triaging the patient and stratifying risk. What immediate problems is the patient experiencing, and how might that be precipitating the event that they have? And then obviously stratifying risk. Are the patient's suicidal thoughts related to serious intention? Do they have a plan? Or are they more transient thoughts without intention? And that can be the difference between needing a patient to be hospitalized or managing them outpatient. So one particular patient that I think of when I think about substance use and the importance of triaging and stratifying risk, I saw this young man as an intern in the ER. He had very consistent and very heavy alcohol use disorder. He was in his early 20s, so still super young person. And he actually presented with suicidal thoughts to the emergency room. And that was his primary complaint. Come to find out, he was in very early withdrawal. And I don't know how much you guys know about the experience of withdrawal, but people are absolutely miserable, and it can quickly progress from, tremors, hallucinations, to even seizures and cardiac arrest, which at one point this patient did have. So identifying kind of the precipitating thing and how you can help to help alleviate the crisis can reduce some of those suicidal thoughts, which they did in this patient. Another thing I wanted to touch on is that I find that vulnerable people are more likely to use substances in response to those negative social situations and the high-risk social determinants of health. And it becomes that vicious cycle, right? Where you're using the substance to sort of escape, but then that's bringing you into kind of a darker place, giving you less control over your life. So one group that I think of is pregnant women and women with children. They already are a very vulnerable population. They have kind of an impossible number of things to do. And, in this country, we kind of suffer from a lack of social support for that group. But a lot of women, reproductive age women, are using marijuana, and they don't really see it as a problematic drug, especially when it comes to being harmful to their fetus. I actually think that there's more stigma around cigarettes. But when you think about marijuana in clinic, I don't think about it being as kind of deadly as alcohol with withdrawal and other symptoms. But I definitely think about it as like kind of a gateway to other negative social determinants of health. I don't necessarily see people who use marijuana progress to using hard drugs, like other illicit drugs, but I do see that it kind of erodes some of those social determinants through job loss, contributes to poverty, can have a negative impact on relationships, negative impact on a patient's motivation to change their situation. But I am particularly concerned about the harm it can do to mothers children. So we see harm from marijuana for kids with asthma. We see children who eat THC gummies, and anything negative that happens to your kids, I feel like can precipitate a crisis in a mother too. And obviously, in a clinical setting, we frequently talk about postpartum depression, and that's a huge risk factor for suicidality in postpartum women. We live in a country where we really have a high maternal mortality rate compared to other similar countries. And 8.4% of pregnancy-related deaths are actually from suicide, which is a really high number. And you throw substance use into the mix, and it can just make it impossible for people, I think, who are reproductive age women and pregnant. Another patient I thought about when we were discussing this topic are those patients that they maybe are never in a crisis, but they maybe don't value their life. And I know that this isn't suicidality in the traditional sense, but I had an elderly woman with a many year history of multiple illicit drug use, including methamphetamine. And I asked her many times if she was suicidal, if she thought about killing herself, but she never did. And I don't know if she did and didn't tell me or not, but she was never overtly suicidal to me. But she also showed no desire to curb her drug use or change her situation to save her own life, even though it was obvious that her drug use would kill her. So we had those serious conversations, offered every social service available, including inpatient treatment or a nursing home. And, she never turned it around, and she did end up dying from an overdose while I cared for her. So those are some of the patients that jump out at me. In a clinical setting, even though I'm not a psychologist or a psychiatrist, certainly suicide and substance use have to be on your mind frequently. If you don't ask the questions, you don't know if a patient is in a crisis.